Good afternoon, everyone. My name is Bill O'Brien, and on behalf of the RSNA Educational Committee and our track chair, Dr. Alexander Gomarez, we'd like to welcome you to this MRI case-based review. We have a great lineup of cases covering the pediatric brain, adult brain, spine, and chest. I'll be leading us off with a case-based review of the pediatric brain. I have no relevant financial disclosures or conflicts of interest related to this talk. In terms of learning objectives, by the end of this session, we hope to be able to recognize patterns of neonatal hypoxic ischemic injury, identify characteristic imaging features of some of the more common metabolic brain disorders, and be able to describe imaging features associated with neoplastic causes of epilepsy in children. So let's look at case number one. These are two full-term infants. We have T1 weighted images. One is normal and one has severe hypoxic ischemic injury. So our first question, which T1 image in a full-term neonate shows severe hypoxic ischemic injury? Is it image A or image B? And the answer is image B. So let's take a closer look. In a normal term infant, there is T1 hyperintense myelination in the posterior limb of the internal capsule, which is brighter than the adjacent deep gray matter structures. As we will discuss in a few moments, in the setting of severe hypoxic ischemic injury, there is increased T1 signal intensity throughout the deep gray matter structures, which appear brighter than the myelinated posterior limb of the internal capsules. In terms of the pathophysiology, hypoxic ischemic injury may be due to hypotension or hypoperfusion, or it could be seen in the setting of asphyxia. Preterm infants are especially vulnerable to hypoxic ischemic injury because they have what is referred to as pressure passive flow due to defective autoregulation. That means as their mean arterial blood pressure decreases, they have a resultant decrease in cerebral perfusion. The full extent of the injury is dependent upon multiple factors, most importantly, the severity of injury, duration of injury, and gestational age. Treatment includes therapeutic hypothermia or cooling, which not only improves patient outcomes, but also delays the onset of imaging findings. Therefore, the optimal time for MR imaging to evaluate for diffusion abnormalities is 2 to 5 days of life. Prior to that, you may have false negative restricted diffusion, and towards the end of the first week, diffusion abnormalities begin to normalize. So in terms of the patterns of hypoxic ischemic injury, if you have severe hypoxic ischemic injury in term or preterm infants, we typically see the basal ganglia thalamic pattern. When you have mild to moderate hypoxic ischemic injury, the pattern of injury depends upon the gestational age of the patient. So in full-term infants, we'll see a watershed predominant pattern of injury, similar to what we see in adults. In preterm infants, we're going to see a periventricular white matter pattern of injury. So looking at the basal ganglia thalamic pattern, again, this is going to be severe hypoxic ischemic injury in term or preterm infants. This will affect the central gray matter nuclei. Preferentially, you have involvement of the ventrolateral thalami and posterior putamen. You could also get involvement of the perirolandic cortex and brainstem. These children tend to be severely disabled. And on imaging, what we're looking for is increased T1 and T2 signal intensity with associated restricted diffusion. And then you can see an elevated lactate peak on MR spectroscopy. So here's a full-term neonate who presented with seizures following placental abruption. And on MR, we could see increased T1 and T2 signal intensity involving the deep gray matter structures. With restricted diffusion, we'll see increased signal on diffusion-weighted imaging with associated decreased signal on ADC map. In this case, we could see involvement of the deep gray matter structures with extension into the perirolandic cortex as well. If you perform spectroscopy, again, you're going to see a significantly elevated lactate peak. In normal neonates, you can see a small lactate peak, but this is significantly elevated in the setting of severe hypoxic ischemic injury. So the severe cortical and subcortical pattern of injury is very rare. It tends to be fatal, so oftentimes these patients do not go on to imaging. In non-fatal cases, you're going to see marked cystic encephalomalacia. So on imaging, what you're going to see is marked edema involving the cerebral hemispheres with diffusion restriction in the affected areas. You're going to have sparing of the deep gray matter structures, and then you get characteristic sparing of posterior fossa structures, including the brainstem and cerebellum, which gives this white cerebrum appearance on diffusion-weighted imaging, where the cerebral cortex is involved and the posterior fossa is spared. And looking at mild to moderate hypoxic ischemic injury in full-term infants, we're going to see the watershed predominant pattern of injury. And this is going to affect the border zones between the anterior middle and posterior middle cerebral artery territories. If you have a central cause, which oftentimes we do, the findings are typically going to be bilateral, but they may be asymmetric. And the long-term outcomes are variable. It just depends where on that spectrum from mild to moderate you fall in terms of the hypoxic ischemic injury. So here's an example of a 2-day-old infant with seizures in the setting of hypoxic ischemic injury. T1 and T2 weighted images show cerebral edema in a watershed distribution with gyral expansion, loss of gray-white matter differentiation, and sulcal effacement with associated restricted diffusion. So in terms of mild to moderate hypoxic ischemic injury in preterm infants, we're going to see a periventricular white matter pattern of injury where you get preferential involvement of the deep hemispheric white matter and sparing of the deep gray matter structures. So on imaging, oftentimes in the neonatal period, you're going to see T1 hyperintense foci. T2 signal is more variable. It can be hypointense or hyperintense, and you can see associated diffusion restriction or hemosiderin deposition. As you get more severe injury, you could get frank periventricular leukomalacia, where you have a posterior predominant deep white matter volume loss with or without cystic changes. So here's an illustrative case of a 34-week gestational age infant with mild perinatal hypoxic ischemic injury. And on MR, we see small foci of T1 hyperintensity within the posterior periventricular white matter. And in this case, they are T2 hypointense. Then here's an adolescent that has classic periventricular leukomalacia associated with a neonatal ischemic injury. So on FLAIR imaging, what we could see is deep hemispheric white matter volume loss with a posterior predominance. We have associated ventriculomegaly with characteristic angular margins. And then there are confluent areas of signal abnormality within the periventricular white matter. So let's look at case number 2. This is a child who presented with developmental delay. We have axial T2 and FLAIR imaging. So question number 2, what is the most likely diagnosis based upon this single FLAIR image? Is it A, Alexander disease, B, Canavan disease, C, metachromatic leukodystrophy, or D, adrenoleukodystrophy? And the answer is C, metachromatic leukodystrophy. So metachromatic leukodystrophy is the most common inherited leukodystrophy. This is a lysosomal storage disorder which results from a deficiency in aryl sulfatase A. So you get an accumulation of toxic metabolites as a result of that enzymatic deficiency. There are 3 forms of the disorder, with late infantile being the most common. So on imaging, what we're going to see is bilateral, symmetric, and confluent areas of signal abnormality involving the deep, greater than superficial hemispheric white matter. We're going to get sparing of the subcortical U fibers early on in the disease process, and then you get sparing of the perivenular white matter, which results in characteristic tigroid or leopard pattern within the area of signal abnormality. Typically, there's no enhancement, although you can see faint linear punctate parenchymal enhancement, and then you can see cranial nerve enhancement as well in the setting of metachromatic leukodystrophy. So next is adrenoleukodystrophy. This is an X-linked inherited peroxisomal disorder where you get an accumulation of very long-chain fatty acids. And that results in an inflammatory dysmyelination and demyelination. Most common variant is a posterior variant where you're going to see confluent areas of signal abnormality within the deep hemispheric white matter. Early involvement of the splenium of the corpus callosum is characteristic. Early on in the disease process, you'll get sparing of the subcortical U fibers, and we're going to see 3 zones of involvement. You have a central or inner area of gliosis and scarring that's T2 hyperintense, a thinner peripheral leading edge of T2 hyperintense demyelination, and then you're going to see this intermediate area of active inflammation and enhancement. Next is Alexander disease, which is also known as fibrinoid leukodystrophy. And this enzymatic deficiency leads to accumulation of Rosenthal fibers. It's usually diagnosed in infants, but you have neonatal, juvenile, and adult variants that are less common. Classically, on clinical presentation, patients will present with macrocephaly, and on imaging, we're going to see symmetric, frontal predominant signal abnormality within the hemispheric white matter. You're going to have early involvement of subcortical U fibers, which is common to these macrocephalic leukoencephalopathies. And then you can have deep gray matter involvement, which, like the white matter involvement, goes from anterior to posterior. So you have involvement of the caudate, followed by the lentiform nucleus, followed by the thalamus. And enhancement is typically seen and is characteristic of Alexander disease. So lastly is Canavan disease, where you have a deficiency of N-acetyl-aspartyl-acylase, which leads to an accumulation of NAA. Most cases present in infancy, and you have an early mortality. So classically on clinical presentation, they're going to have macrocephaly. And on imaging, what we're going to see is symmetric white matter signal abnormality with early involvement of subcortical U fibers. You do not have that frontal predominant pattern like we see with Alexander disease. You can't have deep gray matter involvement. Most often it involves the globi pallidi and the thalami. And along with the distribution, you will not see enhancement, which helps differentiate this from Alexander disease in the setting of macrocephaly. MR spectroscopy is characteristic in pathognomonic, where we're going to see a significantly elevated NAA peak that's characteristic for Canavan disease. Most other disease processes actually result in a decrease in NAA. So our last case, case number 3, this is an adolescent who presented with seizures. We have axial T2, flare, and T1 post-contrast images. So question number 3, dural enhancement or a dural tail is more often associated with which of the following cortically based cystic and solid masses? Is it A, ganglioglioma, B, dysembryoplastic neuroepithelial tumor, C, juvenile polycytic astrocytoma, or D, pleomorphic xanthorastrocytoma? The answer is D, pleomorphic xanthorastrocytoma. So when we're looking at cystic and solid cortically based masses in children that present with seizures, our primary differentials are going to be ganglioglioma, dysembryoplastic neuroepithelial tumor, and pleomorphic xanthorastrocytoma. So what are the commonalities amongst these lesions? Well, most often patients present with seizures, and it commonly presents in children, adolescents, and young adults. These lesions can involve any lobe, but by far temporal lobe is most common location. These are low-grade, slow-growing, cortically based lesions, so you can see overlying bony remodeling. So ganglioglioma is the most common neoplastic cause of epilepsy in children. It's a neuroepithelial tumor, so you have neoplastic ganglion and glial cells. On imaging, what we're going to see is a cystic mass with a mural nodule, and you'll see enhancement and or calcification in approximately 50% of cases. Next is dysembryoplastic neuroepithelial tumor. So DNET is important because it's associated with an underlying cortical dysplasia. So you have to have surgical resection of both the lesion and the cortical dysplasia to get seizure resolution. On imaging, what we're going to see is a T2 hyperintense cortically based mass. Classically, it's going to be nodular, pseudocystic, or bubbly. And despite the size of the lesion, there's usually little mass effect and no significant edema. And you can see calcification or enhancement in about 20 to 30% of cases. And then lastly is pleomorphic xanthorastrocytoma. This is a supratentorial peripheral astrocytoma. So on imaging, what you're going to see is a cortically based cystic mass with a mural nodule with varying degrees of surrounding vasogenic edema. And the enhancing nodule typically abuts the meninges, so you can see dural enhancement. So if you see that dural enhancement, that's the one time you would put PXA above ganglioglioma on your differential. Otherwise, ganglioglioma will always be your leading differential because it's much more common. So in summary, we looked at the different patterns of neonatal hypoxic ischemic injury, emphasizing that it's really dependent upon the severity and duration of injury as well as gestational age. We looked at some of the characteristic imaging features of the more common metabolic leukodystrophies, and then we looked at the imaging features of common neoplastic causes of seizures in children, which are ganglioglioma, DNET, and PXA. So I want to thank you for your time and for tuning in to this session. It is now my pleasure to introduce our next speaker, Dr. Pina Sinelli, who is a professor of radiology at the Hofstra School of Medicine and a past president of the American Society of Neuroradiology.
It is my pleasure to present a case-based review on MRI of the adult brain. Although I have no significant disclosures, I would like to acknowledge that I am an editor for the textbooks on Neuroimaging, the Essentials, and Case-Based Brain Imaging, which have contributed cases to this presentation. The learning objectives are focused on highlighting the key imaging diagnostic features on MRI and important imaging pearls for differentiating adult brain pathology. The first case today is a 50-year-old male presenting with new onset transient aphasia. Patient has a family history of young stroke onset. MR images using FLAIR demonstrate extensive hyperintense signal abnormalities involving the periventricular and subcortical white matter with several confluent areas bilaterally. There is extensive involvement of the corpus callosum as well. Additionally, there are multiple hyperintense lesions involving the basal ganglia and a cavitated lacunar infarction. The diagnosis for this patient is CADASIL, which stands for cerebral autosomal dominant arteriopathy with subcortical infarctions and leukoencephalopathy. Our first question is, which of the following imaging characteristics is not seen with CADASIL? A. Large confluent T2 hyperintense signal abnormality in the white matter. B. T2 hyperintensities preferentially in the anterior temporal lobes, external capsules, and corpus callosum. C. Small lacunar infarctions. D. MRI signal abnormality correlates with severity of disease. Or E. Progressive brain volume loss. The correct answer is D. MRI signal abnormality correlates with severity of clinical disease, is not seen with CADASIL. Now let's review some key characteristics about CADASIL. CADASIL is characterized by multiple cerebral ischemic events occurring in the absence of other risk factors. The typical age of onset is around 40 years old. The etiology of CADASIL is due to mutations in the Notch3 gene on chromosome 19. The Notch3 protein is crucial for development and differentiation of vascular smooth muscle cells. The clinical manifestations of CADASIL are mostly confined to the brain. It is a common cause of hereditary vascular dementia. Other important clinical manifestations include psychiatric disturbances such as apathy and irritability, cognitive deficits, and seizures. The definitive diagnosis of CADASIL is made from skin biopsy. The electron microscopy shows dense granular deposits in the basal lamina surrounding vascular smooth muscle cells. On MR imaging, there are several imaging features of CADASIL, including acute lacunar lesions superimposed on chronic ischemic changes as seen in this example. The diffusion-weighted images demonstrate a small area of restricted diffusion in the right frontal white matter corresponding to acute infarction. Extensive T2 hyperintensities predominantly involving the periventricular and subcortical white matter are seen on the T2-weighted images. The extent of MRI abnormalities do not correlate with the severity of the clinical presentation. Rather, progressive brain volume loss correlates with the disease severity in CADASIL. Other imaging features include periventricular T2 hyperintensities, such as the ventricular caps, which often is the first imaging sign in young asymptomatic patients. In this case, there are periventricular white matter disease predominantly seen as ventricular caps in the frontal lobes and in the external capsules bilaterally. Cerebral microbleeds are seen in CADASIL on susceptibility-weighted images, representing subclinical blood leakage with hemosiderin deposition. An increased number of microbleeds are associated with high morbidity, and lobar hemorrhages may also occur. Here is a side-by-side comparison of a mimic and lookalike for CADASIL. Similar imaging findings are seen with confluent T2 hyperintense signal involving the white matter and several chronic lacunar infarctions. However, there is relative sparing of the temporal lobes and corpus callosum. This is a case of Binswanger's disease, also known as subcortical arteriosclerotic encephalopathy, which is a cause of vascular dementia and due to chronic long-standing hypertension in older age. The imaging pearl for CADASIL is the T2 hyperintensities in the white matter preferentially found in the anterior temporal lobes, external capsules, and corpus callosum. These MRI findings help to differentiate CADASIL from other similar entities in the differential diagnosis. Case 2. The history is a 38-year-old female presenting with acute onset of mental status changes. The MRI FLAIR images demonstrate multiple small scattered hyperintense signal abnormalities involving the periventricular and subcortical white matter bilaterally. There is associated enhancement with one of these lesions on the post-contrast T1 weighted images. Additionally, there is a focal cortical hyperintense signal associated with restricted diffusion, representing acute infarction. The diagnosis for this young patient with acute stroke is SLE, systemic lupus erythematosus. The question for this case is, the differential diagnosis of SLE should include all of the following except A. Multiple sclerosis, B. Antiphospholipid antibody syndrome, C. Herpes encephalitis, D. Lyme's disease, or E. Susac syndrome. The correct answer is C. Herpes encephalitis. Let's review the key characteristics. SLE is defined as an autoimmune disease that affects many organ systems. The clinical presentation may include neuropsychiatric symptoms seen in up to 70%. The highest incidence occurs in women aged 20 to 40 years old, and laboratory tests with elevated ANA and anti-dsDNA. The treatment is focused on immunosuppressive therapy and anticoagulation. The prognosis varies, with the mortality rate of up to 40%. The imaging features of SLE can present in different patterns as depicted in these case examples. The first is a common pattern that we saw in the index case, where there are scattered small T2 hyperintense lesions in the white matter. The second pattern is predominantly gray matter involvement in the basal ganglia, with possibly cortical involvement. And the third pattern is extensive confluence signal throughout the periventricular and subcortical white matter. Other imaging features include contrast enhancement of acute and active lesions, as we saw in the index case and this case of predominantly basal ganglia involvement. Vascular imaging of SLE may reveal multifocal stenoses and dilatations of the proximal and distal arterial branches representing lupus vasculitis, as shown in this case predominantly involving the proximal and distal segments of the anterior cerebral artery. In SLE, advanced imaging with PET may show increased FDG uptake corresponding to acute inflammation and possibly hypometabolism in the parieto-occipital lobes. Characteristically, patients who are antiphospholipid antibody positive have a much higher risk of stroke and venous sinus thrombosis, as seen in this case with the left temporal hemorrhagic stroke due to transverse and sigmoid sinus thrombosis. Here is a side-by-side comparison of a mimic and lookalike for SLE, showing similar findings as the index case, with multiple small scattered white matter lesions on FLAIR, associated with the lesion enhancing, representing active inflammation. The mimic case is multiple sclerosis, which is an inflammatory demyelinating disease which characteristically involves the periventricular white matter, corpus callosum, and centrum semiovale. The periventricular white matter lesions in multiple sclerosis may be oriented perpendicular to the lateral ventricles, known as Dawson's fingers. The imaging pearl in recognizing SLE is the combination of arterial and venous infarctions of various stages with multiple scattered small white matter lesions, particularly in the setting of progressive cerebral atrophy in a young patient. These MRI findings can help differentiate SLE from other similar appearing entities. Case 3. History is a 42-year-old female presenting with headache and new confusion. MRI FLAIR images demonstrate patchy scattered hyperintense white matter lesions in the supratentorial and infratentorial white matter bilaterally. The post-contrast T1 weighted images reveal associated enhancement in several lesions. The diagnosis in this case is PACNS, primary angiitis of the central nervous system. The question for this case is, which of the following statements is false regarding primary angiitis of the central nervous system? A. Most commonly affects small leptomeningeal and cortical arteries. B. Men and women are equally affected. C. CSF profile is normal in most patients. D. Invasive procedures, including angiography and brain biopsy, are frequently required to make the diagnosis. Or E. A negative brain biopsy does not exclude the diagnosis. The answer is C. CSF profile is normal in most patients. Let's review some key characteristics. PACNS is defined as a non-infectious granulomatous angiitis, which most commonly affects small arteries and veins. Patients most commonly present in the 4th to 6th decade. Men and women are roughly equally affected. Laboratory analysis reveals abnormal CSF profiles with mononuclear pleocytosis with or without increased protein levels. The diagnosis is typically made by invasive procedures, including angiography and/or brain biopsy. It is important to recognize that a negative brain biopsy does not exclude the diagnosis of PACNS. Unfortunately, there is no specific therapy, and it is a rapidly progressive disease with a poor prognosis. The imaging features of PACNS include multifocal areas of T2 hyperintense signal abnormality, with a predilection for the basal ganglia and subcortical white matter. The cerebellum and brainstem may also be involved, as seen in our index case. Other imaging features include contrast enhancement, frequently associated with the white matter lesions, and leptomeningeal enhancement with minimal underlying parenchymal involvement. PACNS may also present with focal acute subarachnoid hemorrhage or small parenchymal hemorrhages in the cortex, as seen in this case on CT and MRI. Vascular imaging reveals segmental narrowing or beading of the distal vessels in multiple areas, which typically affects more than one vascular territory, as seen in this index case involving the middle and posterior cerebral arterial segments. Here is a side-by-side comparison of a mimic and lookalike for PACNS, showing similar findings as the index case, with small scattered white matter lesions and chronic lacunar infarctions. However, vascular imaging reveals irregular short segment narrowing involving the proximal M1 segment of the middle cerebral artery, representing atherosclerosis. Imaging pearl for PACNS is linear or tram track enhancement due to the vascular and perivascular involvement on MRI, as seen in this case example, and segmental narrowing and beading involving the distal arteries on angiography. These findings may help differentiate PACNS from other similar appearing entities. In summary, we have reviewed several different etiologies of young stroke presenting as predominantly white matter disease. Each of the cases had key diagnostic features valuable in detecting these specific CNS pathologies, with the imaging pearls helping to differentiate from mimics and lookalikes. Thank you for your attention today. I would like to introduce our next speaker in the case-based review course on MRI of the spine, Dr. Pia Malli-Sundgren from the Lund University Bioimaging Center.
Good afternoon, and thank you for listening in on this lecture on MRI of the spine. I have no conflict of interest to this lecture and topic. So let's start with the first case, a 45-year-old female that presents with mild weakness in left arm, complete plegia in left leg, and moderate weakness in the right leg. And this has progressed bilaterally to sensory level T3. She also has hiccups and nausea. Here you can see the sagittal T1 and T2 weighted images, and you can see there are signal abnormalities within the spinal cord, and on the T1 weighted postgadolinium to the right you can see there is some focal areas of patchy enhancement, especially in the cervical spinal cord. So my first question is, which additional imaging might be helpful for the diagnosis? And you have the choices A, B, C, and D. The correct answer is MR of the brain and the optic nerve. Let's look at the brain. In this disease, the brain MRI might be normal. It might present with specific findings, and sometimes they would have very unique findings. And these are signal abnormalities in regions with an increased aquaporin 4 channels. So what is the most likely diagnosis? Neurosarcoidosis, ADEM, neuromyelitis optica, or transverse myelitis? This is a case of neuromyelitis optica, NMO. Hiccups and nausea is unique symptoms in neuromyelitis optica, and there is a relationship between the patients presented with incurable hiccups and nausea, and that is area postrama and nucleus tractus solitarius. And as you can see on the image, there are some signal abnormalities on the sagittal T2 weighted images in this area, which can explain the patient's symptom. So NMO represents an extensive demyelination of the white and gray matter. It usually has a relapsing course and is more commonly seen in females. Typical imaging findings that we can see in the spinal cord is T2 signal abnormalities that extends more than 3 vertebral segments. You might see contrast enhancement that can be focal or patchy. You would have a cord swelling, and as a sequela, the spinal cord might be atrophic in up to 20%. Case number 2. This is a 3-year-old girl with ataxic walking and right-sided ptosis. Here we can see the sagittal T2 weighted images and T1 post-gadolinium, as well as axial T1 weighted after gadolinium. And what you can see is there is signal abnormality and pathological contrast enhancement of the posterior spinal nerve roots at the level of the conus. If we are looking at this patient's brain, you could see that there is pathological contrast enhancement of several of the cranial nerves. So what is the most likely diagnosis in this case? NMO, Guillain-Barré, Miller-Fisher syndrome, or Lyme's disease? It is a case of Miller-Fisher syndrome. So, Miller-Fisher syndrome is characterized by the triad of ophthalmoplegia, ataxia, and reflexia. It's often linked to preceding infection with Campylobacter jejuni or Haemophilus influenza. And often you will see antibody against GQ1B ganglioside. Imaging-wise, in patients with Miller-Fisher syndrome often have affected cranial nerves, and more commonly you see involvement of the posterior spinal nerve roots. Let's go to case number 3. A 14-year-old girl presenting with sensory disturbances, sphincter disorder, and mental status change 3 weeks after vaccination. Here you see sagittal T2 and T1 weighted images after gadolinium. As you can see, there is extensive signal abnormalities within the spinal cord, involving most of the cord, but most extensively seen in the thoracic region. And also on the T1 weighted post-gadolinium images, you will see focal faint areas of patchy contrast enhancement. If we look at this patient's brain, you could see that you have flare signal abnormalities subcortically in both frontal lobes, as well as involvement of the cerebellum. This is a case of acute disseminating encephalomyelitis, ADEM. It is an autoimmune mediated demyelinating disorder of the CNS, commonly affecting children and commonly occurring within 3 weeks after infection, vaccination, or medical treatment. In up to 30%, you would have spinal cord involvement. And typical lesions that you will see could be continuous signal abnormalities, but you may also see segmental involvement with an increased T2 signal. And as in this case, you might have areas of focal or patchy contrast enhancement. So some key points when it comes to spinal inflammation. Commonly, you will see T2 signal hyperintensities. You may have focal or patchy contrast enhancement. You might see in the acute stage cord enlargements. And as we all know, there is a questionable overlap between the acute transverse myelitis and multiple sclerosis, but also between NMO and multiple sclerosis. And I would highly recommend that you add additional imaging of the brain that might be helpful for the diagnosis. Let's go to case number 4. 12-year-old girl with multiple visits to the ER due to back pain. Here we have a sagittal T2-weighted images of the spine. And as you can see, there are multiple foci within the vertebral bodies in the lumbar and lower thoracic vertebra, as well as a vertebra plana of the C5 vertebral body. So what is the most likely diagnosis? Ewing sarcoma, chronic recurrent multifocal osteomyelitis, tuberculosis, or multiple hemangiomas. In this case, it was a case of chronic recurrent multifocal osteomyelitis. And here again, you can see some of the abnormalities that we could see on these limited images. So chronic multifocal osteomyelitis is an autoinflammatory disorder that mostly affects children. It has an unclear etiology. Typical symptoms is periodic aching bone pain and fever. And you could have involvement of multiple bone lesions anywhere in the skeletal site. As this is usually a sterile osseous inflammation, biopsy is often not needed. And typical differential diagnosis to think of is tuberculosis, Langerhans cells histocytosis, or malignancy. Chronic recurrent osteomyelitis has usually a long fluctuating course. It's often a diagnosis of exclusion and response to NSAID. The spine will be involved in 1/3 of the cases sometime during the illness. The patient may present with rigidity, pain. Often the lesions are multifocal. And as you saw in this case, it may progress to vertebra plana and also to kyphosis. Final case, a 9-year-old boy complaining of back pain after falling on rollerblades. These plain films do not demonstrate any fracture or any alignment, malalignment. He comes back 2 months later, complaining of continuous pain and now decreased strength in the left leg, and he also presents with periodic fever. The sagittal CT demonstrates compression of the vertebral body and slight kyphosis. If we are looking at the MR images, you could see that you have the compression of the vertebral body. You have perilesional or perivertebral soft tissue, which is pathologically contrast enhancing and is extending into the epidural space. So what is the most likely diagnosis? Ewing sarcoma, tuberculosis, spondylodiscitis, or none above? This was a case of tuberculosis. So tuberculosis usually is secondary to extraspinal infection, but may in the children be the initial manifestation. It's increasing in the Western worlds. Usually the infection starts in the anterior vertebral body and spreads under the anterior longitudinal ligament to adjacent vertebra. Rarely it could start in the vertebral body and spread like a bacterial spondylodiscitis, or even start in the vertebral body and invade the spinal canal alone. Most commonly, it's located in thoracic lumbar region. In children, you might say discitis. Otherwise, usually you would have a spare disc and you might see skipped lesions. So my take-home message is clinical information is important for the diagnosis. Use dedicated imaging protocol. Do not forget to use gadolinium if you have a suspicion of infection, inflammation, or neoplasm. And brain imaging might be a valuable adding for the final diagnosis. Thank you very much for your attention. And it's my pleasure to present the next speaker that will be talking about MR of the chest.
Hello, my name is Sanjeev Bala, and I'm from the Mallinckrodt Institute of Radiology at Washington University in St. Louis. For the next 10 minutes or so, we're going to be discussing a few cases using thoracic MR in order to further our diagnostic skills. I should begin by saying I have no financial disclosures. Our main goal is to have a good time while looking at a few cases so we can leave you with some take-home points so you can use in practice as soon as tomorrow if you wanted. Here's the first case. This is a 28-year-old woman that we saw in our hospital who presented to the emergency department with palpitations. You can see that the images on top are from a pulmonary embolism protocol. The original reader determined that there was an enlarged thyroid and there was a mass that was sitting in the anterior mediastinum. It was this mass that prompted a thoracic MR. Here are a few select images below of the in and a post-phase images at 2 stations through the chest. The first question then is, what's the best diagnosis for this finding? Is it a teratoma, a thymoma, thymic hyperplasia, or thymic cyst? And I'll draw your attention again. Here are the in-phase images here on the left and the post-phase images on the right. And you can see the India ink artifact to help. And most of you looking at this case are noticing that this mass is dropping on the opposed phase. It's losing signal, and you'd be correct in assuming that this is thymic hyperplasia. So a word on thymic hyperplasia or thymic rebound. It is often described as occurring in 2 forms. There's the true rebound, which can sometimes be nodular or thymic in shape, and it is usually something that follows a stressful situation like chemotherapy, radiation therapy, steroids, or burns. Now, there's another form of thymic hyperplasia or rebound that is known as a lymphoid hyperplasia. It's not distinguishable on imaging, but this can be seen in the setting of lupus, Graves' disease, myasthenia, and rheumatoid arthritis. This, as you would imagine, with a select cut right through the thyroid, was a patient presenting with an initial manifestation of Graves' disease. useful to think about that Graves is associated with thymic hyperplasia because in our practice, we've seen a handful of young people present to the emergency department with symptoms of either an acute myocardial infarction or pulmonary embolism. And it's turned out they've gotten one of these CT protocols, which have later demonstrated findings of thymic hyperplasia. Here, another example. This is an 18-year-old boy that we saw at our children's hospital with hemoptysis. And the original reader picked up correctly that there was an infiltrating mass that was within the mediastinum. Now, this one, you'll notice, goes behind the brachiocephalic vein. Again, the question arose as to what this mass represented, and the patient was referred for MR. Just to show you some select images, this is the in and the opposed phase image. Again, there's some signal dropout. You can see that on diffusion weighting, there's no diffusion restriction, and this area does enhance. So the question then becomes, when you see this mass with loss of signal on the opposed phase image, what does it represent? This was another example of chemical shift artifact, and as you would imagine, this ended up being an example of thymic hyperplasia. This was extending behind the brachiocephalic. This retrobrachiocephalic venous thymus is sometimes seen, and MR was very helpful in making the diagnosis. Now, a lot of the work relies on an original publication that came out of radiology in 2007, where thymic hyperplasia was compared and contrasted with thymic gland tumors. An entity known as a chemical shift ratio was used, and if there was a signal on the opposed phase image, which was less than 80% of the signal that was detected on the in phase, it actually showed a pretty high score for determining if a patient had thymic hyperplasia. And you can see our patient actually is falling below this number, but within the standard deviation. Now, if to make the chemical shift ratio work, we have to be using a dual echo technique where the in phase and the opposed phase sequences are obtained simultaneously. Now, if there are different echoes, you actually have to normalize to the muscle. So you'd get your signal of your in phase compared to skeletal muscle, and then your out of phase compared to skeletal muscle, and use that ratio to help make the determination. In other words, if there's more than 20% to 25% drop in signal, then you have a quantitative value that you can reliably say there's dropout. We usually rely, however, on the qualitative dropout. All right, here's the next case. This was a 24-year-old woman who was pregnant and presented to our hospital with dyspnea. Because of her pregnancy, she was referred for MR, and here's some select images through her thoracic MR. They include a coronal proton density weighted haste. You can see that there's a T1 and a T2. Here's diffusion restriction, so it did show some diffusion restriction, and the in and opposed phase images. Now, based on these images, where the chemical shift ratio is greater than 1 and there is diffusion restriction, what's the most likely diagnosis? Is it a lymphoma? Is it a germ cell tumor, thymic hyperplasia, or a thymic cyst? And again, we look at the fact that this is not dropping on a post-phase image. It's quite mass-like, making hyperplasia very unlikely. And as you would expect, this was a lymphoma. Now, some clues to the lymphoma were that it was a large mass, and this is a woman. Malignant germ cell tumors are very unusual in women. The other is that you can see on the original T1 images with the in and opposed phase that there's some extension into the superior vena cava. Here's some balanced steady state free precession images which showed this involvement of the superior vena cava as well as an embolism in the left lower lobe. This extension into the superior vena cava is quite good for a lymphoma. In fact, in our practice, the most common cause for a mass extending through the superior vena cava is probably a B-cell lymphoma. This was a child who also had the same diagnosis. Thymic carcinomas and small cell carcinomas can occasionally present initially with a filling defect and intravascular extension through the superior vena cava. Here's another patient who presented with an anterior mediastinal mass that was somewhat rounded, and this was incidentally detected on imaging performed for another indication. This mass was kind of weird, and the patient went on to get a MR as well as a PET. Now, you'll notice on the FDG PET, there wasn't much uptake on both the fused images with the MR or the PET CT. There wasn't much in the way of diffusion restriction either, as there's some T2 shine through. You'll notice that it doesn't drop on a post phase, and there is some enhancement. So the question arises in this situation, in a 58-year-old with an incidental anterior mediastinal mass, what's the most likely diagnosis? And in this case, this ended up being a thymoma. That's not surprising, as thymomas represent the most common incidental mass in older patients within the anterior mediastinum. But you'll notice, again, that unlike thymic hyperplasia, there's no dropout, and germ cell tumors would be unusual in a patient of this age. Just to kind of show what a classic thymic cyst would look like, here is the T1 weighted image and the T2 stir, which shows that it's quite bright signal. It's homogeneous. There's no enhancement on the post-contrast images. Notice that there's somewhat of a triangular shape, which is very typical of many thymic cysts, though not a requirement. Now, two examples of patients, one to the left of the yellow line and one to the right. The question arising, are these thymic cysts? Well, on this patient, you'll notice on the post-contrast image, there's some enhancement of a nodule, and the answer is no, this was not a thymic cyst. It was a superior mediastinal enhancing cyst, and this ended up being a thyroid cancer, which is not surprising given the small nodule. This lesion in the anterior mediastinum had some rim enhancement, which would also be very atypical for a thymic cyst. And in this case, this ended up being a cystic thymoma. So useful to keep in mind that if there's enhancement, it's very unlikely to be a classic thymic cyst. What about another role for chemical shift artifact in the chest? This was a gentleman who was stung by a bee in the left supraclavicular fossa. After surgical exploration, developed bilateral pleural effusions, as in this case. There was also an incidental lesion within the liver that prompted an MR. And on the MR images, we had in and opposed phase imaging through these pleural effusions. And so the question arises this time, what is the best descriptor for these pleural effusions? Are these representative of hemothoraces, chylothoraces, transudates, or empyemas? Now, these are dropping on the opposed phase image, and those of you who picked that up very accurately thought that this would be a very good appearance for a chylothorax. Just a word about chylothorax. Chylothorax usually follows trauma or surgery. Rarely does it follow infection or neoplasm, but congenital causes of chylothorax are well known, including lymphangioliomyomatosis and a much rarer condition, lymphangiomatosis, where you get lymphangiomas within the bronchovascular bundle and also get chylothorax that is accompanying, as in this other patient who is in their late 20s. Sometimes looking at the lung parenchyma can be useful as well on MR, whether the study is performed for evaluation of the lung parenchyma or more commonly because the lung parenchyma is included on the study. Here you can see there's a quite bright T2 parenchymal consolidation. And the question arises, what does this represent? Is this a pneumonia, a pulmonary infarct, lung cancer, or sarcoma? And everyone clearly is thinking that this is going to be an infarct. You can see the pulmonary embolism and the lack of enhancement. MR is a pretty robust tool for evaluation for the characteristic of an embolism. We do want to remind you, however, that the signal characteristics of an infarct are often quite bright. This was a patient with septic emboli who received a thoracic MR for other indications, and you could see that in the lung, there were multiple infarcts that were present, very T2 bright. So an example of a patient that we evaluated who had a filling defect, kind of reminding us that MR can be useful for the evaluation of a filling defect or embolism. The question arose as to what this mass represented. The patient received an MR and we were able to give contrast, and you can see that it's kind of fixed to the pulmonary artery wall. There is some enhancement, and this would be very atypical for a bland thrombus, and as you would expect, ended up being a PA sarcoma. So kind of a quick tour de force through a bunch of different cases of the thorax, but just to remind you that thoracic MR does have some roles. In our practice, the main has been really for the evaluation of mediastinal masses to see if they're purely cystic, if they're enhancing elements, which may sway us away from classic cystic lesions. We also have used it for evaluation of thymic hyperplasia. A reminder that if you're dealing with patients who've got T2 bright signal on MR, you might think about things such as an infarct. And if you want to further characterize an embolism, in addition to using a nuclear medicine study such as an FDG PET, it can be very useful to consider doing MR with contrast for further evaluation for the embolism. I thank you very much for the attention, and I hope that you've enjoyed and continue to enjoy the rest of this virtual conference. Thank you.